came across his research back in 2017, 2018 when I was doing my PhD. I was able to get in contact with him. I met him, had a wonderful visit, and I was just impressed by his genuine care that he has for people and for his dedication to the research. And I'm just grateful for his support with this conference. Now I'll read his bio. Professor John Kerr, MD, is a distinguished cardiac intensive care physician at Boston's Children's Hospital. Since joining the Heart Center in 2010, he has dedicated himself to caring for critically ill children with congenital heart disease. Dr. Kerr is an associate professor of pediatrics at Harvard Medical School. His translational research lab has been continuously federally funded for more than 16 years to develop innovative diagnostics and treatments for oxygen deprivation, including the development of injectable oxygen to reduce patients from profound hypoxemia, and the translation of hydrogen gas from animal to FDA regulated human trials. His dual commitment to clinical excellence and research innovation drives his mission to bring life saving technologies to market. Please welcome Professor Dr. John Kerr.
Hi there, my name is John Kerr, an associate professor at Harvard Medical School and a staff physician in the cardiac intensive care unit at Boston Children's Hospital. It's my pleasure today to present to you hydrogen gas as a treatment for ischemia and ECPR events. I have no relevant disclosures to this talk. I do have funding from the National Institutes of Health and from the Department of Defense in the United States. So we're going to be talking about today is a new treatment for cardiac arrest. And of course, cardiac arrest can be caused by an arrhythmia or myocardial infarction, a variety of other reasons. But the treatment for cardiac arrest includes CPR or cardiopulmonary resuscitation, the provision of oxygen, as well as resuscitative medications and rhythm-directed treatments. And for patients in whom CPR and conventional measures are ineffective, in the US and abroad, there's a growing interest in treating patients with refractory cardiac arrest with extracorporeal cardiopulmonary resuscitation, or ECPR, which essentially involves emergently putting a patient onto ECMO, or extracorporeal membrane oxygenation. And for anybody who's not familiar, that's essentially a heart-lung machine that removes blood from the body, oxygenates it, and pumps it back in, replacing the function of the heart and lungs and providing support to the body while the heart can be resuscitated. So the standard of care following treatment of cardiac arrest, and this really includes ECPR patients, is largely supportive. So that includes, of course, mechanical ventilation, hemodynamic monitoring and treatments, including inotropes, different cardiovascular interventions, including cardiac catheterization, neurologic assessments, but there's really no directed treatment to protect the brain and other organs from the ischemia and subsequent reperfusion, except for targeted temperature management, which is a whole field unto itself, and the gains that have been realized from targeted temperature management, I would say, are modest, and I think that's the view of the field as a whole. So because of this, we have been growing in our use of ECPR. You can see here, this is a trial from the pediatric field that was published in the mid-2010s that really describes the benefits of ECPR and improving neurologically favorable outcome as well as survival to discharge. You can see here over on the right-hand side, the survival to discharge is 40% versus 27%, and the favorable neurologic outcome is about 2.8 times more likely when ECPR is used in refractory cardiac arrest. So that is now a mainstay, and I would say standard for patients both in the pediatric and adult population who have refractory cardiac arrest, who do not have a sort of a life-limiting condition as a contraindication to that. However, outcomes are still quite poor. Although we have improved mortality, you saw the improvement in neurologically intact survival was still quite low, and that is commensurate with our and the experience across the country in the U.S. So here are two studies. One was a nationwide study from 32 centers and the Get with the Guidelines registry. With a median cannulation time, that's the amount of time it takes to put a patient onto ECMO, of 48 minutes. Those patients still had about a 60% mortality rate or a 40% survival to hospital discharge. And cannulation time was associated with mortality rate. Here at Boston Children's Hospital, we examined about a decade of experience. We have a shorter cannulation time, almost half the amount of time, but still have quite a high mortality rate. And about 50% of those patients die due to severe ischemic injury. So that's brain, kidney, or the combination of those two injuries. So with that in mind, we gained a new interest in hydrogen as a treatment for these patients. So as this group is very familiar, this work has been pioneered by several members of this institute and who have shown that hydrogen, or hydrogen as I like to call it, water generating, is known to be highly reactive with oxygen and oxygen species, and to reduce chemically the hydroxyl radical, which is a direct damager of DNA and lipid membranes. And so this is, thought to be a very effective mechanism to diminish both direct injury as well as the downstream effects. And I'm not going to belabor this, but just to pay homage to the wonderful work in this field that was pioneered by Dr. Ota and his group in Japan. And this is really the picture and the paper that garnered my interest and the interest of many others, showing the attenuation of ischemic injury through the administration of hydrogen in a mouse model of middle cerebral artery occlusion. So after reading that paper, we got some funding from the American Heart Association to do first a preclinical trial. So this is before we did anything in a patient. We did this work in a swine. And the model that we used in swine was to take neonatal or baby swine and to create a warm circulatory arrest injury. So this was a global injury. We cooled down to 25 degrees, which is incompletely protective, and then performed 75 minutes of circulatory arrest and then rewarmed. And you can see here in red, we administered hydrogen both before and for 24 hours thereafter, after the injury, almost 24 hours. It turned out to probably be about 18 hours. We then survived swine for up to 3 days and ended with brain MRI and neurohistopathology. Importantly, we administered the hydrogen directly through the ventilator. So I know there are different ways that different groups have administered hydrogen kind of throughout the experience, both the preclinical and clinical experience. We did it this way. So we obtained 2% hydrogen with balanced oxygen, 2% hydrogen with balanced air, and we put them directly through the unmodified ventilator and also through the bypass membrane. We'll show you some validating that work that we've done in that space. But this was really the first time we were able to administer hydrogen in this way. Was in the PIG lab. And we did a lot of diligence with the Boston Fire Department, with NIOSH, and other regulatory agencies within the United States, and found this to be safe. So administering hydrogen in this way significantly diminished the degree of injury. So a higher score, this is a deficit score, so a higher score in the control group showed worse injury or more severe deficits. And you can see here that the hydrogen group had significantly diminished injury. There were 8 animals in each of these groups. What you're seeing here is GFAP, which is the glial fibrillatory acidic protein, which is an astrocyte brain biomarker that's rapidly released into the plasma. And you can see here the significant decrease in change from baseline in hydrogen-treated animals at 60 minutes compared to the control group. And this is really consistent with the group that, or the data shown by Dr. Ota, that the early administration of hydrogen is critical to its efficacy. What you're seeing here is a brain MRI composite image. So this is the median degree of injury shown to the left in a topographical way. So you can see the median injury in the frontal lobe, as well as the temporooccipital lobe was much larger in the control group than in the hydrogen group, and that's shown in graphical format here over to the right. And finally, and somewhat surprisingly, we showed a decrease in serum creatinine, which was very exciting because, of course, renal injury and insufficiency is a major comorbidity in survivors of cardiac arrest. So if we could affect that, that gave us a lot of hope. We then proceeded, having completed this preclinical work, to an FDA-regulated trial of hydrogen in healthy adults. So this was a graded exposure. So the first 2 patients were for 24 hours. The second 2 patients were 48 hours. Then the last 4 patients were 72-hour exposures to hydrogen. So this was 2.4% hydrogen inhaled through a high-flow nasal cannula, just through nasal prongs. And again, these were healthy adult volunteers. So we admitted them to the hospital. We did physical exam and some screening testing, got baseline labs, etc. Then we acclimated them to the high-flow nasal cannula just for symptomatology reasons for 4 hours, and then we began the exposure. And during the exposure, we measured everything you're seeing here, from any symptoms they might be feeling, neurologic symptoms, measured their vital signs, did a mini mental state exam, did a formal neurologic exam from a staff neurologist, a 12-lead EKG, obtained labs at the end of the exposure, as well as pulmonary function testing. And these were done daily for patients who had multiple exposures, or multiple days of exposure, I should say. This was the setup that we used. So these were our source tanks that we received, and the cylinders. The flow was 15 liters per minute, so it was quite a bit of flow. So that's why we had a setup like this, just to facilitate the logistics. The results were quite promising, so there were really no adverse events whatsoever in any patient. There were no clinically significant changes in vital signs, pulmonary function testing, many mental state exam scores, neurologic exam scores, EKG measurements, or any of the labs that we measured. So you can see here, these are all published in this manuscript, but you can see here the changes that we did not see in vital signs. The green, by the way, is the normal range. So this is pulmonary function testing, coagulation profile, and so on. So I refer you to the manuscript for a more complete review of our findings. So now the subject that we come to is the main subject of this presentation, which is what we're calling the hydrogen FAST trial. So FAST is an acronym for feasibility and safety as a therapeutic. So the hydrogen FAST trial. This is a trial that is a multi-center trial. We have 2 centers that are currently enrolling, and probably will add 2 or 3 more before the end of the trial. This is approved by the FDA. It is approved and enrolling at Boston Children's Hospital, and it's funded by the National Institutes of Health. So the design of the trial is 56 participants. There will be 3 patients who are vanguard, so everybody receiving hydrogen, and then thereafter we will randomize the remaining 53 patients in a 32 to 21 ratio. That's what you're seeing there. Patients who are randomized to the hydrogen arm will receive, or are receiving, I should say, 72 hours of treatment of hydrogen, 2% hydrogen, through the ventilator and ECMO membrane. And then I'll go through the endpoints here in a moment. So the inclusion criteria are any patient who is admitted to a cardiac intensive care unit at a participating site with a cardiac comorbidity. So these are going to be all pediatric institutions. So the majority of patients will be children, but there will be some subset of adults who have congenital heart disease. So these patients will generally have congenital heart disease, myocarditis, an arrhythmia, or a rejection of a transplanted heart. These are not adults who have coronary artery disease. Patients are anticipated to be children, but again, any patients of any age can be enrolled. Patients will be experiencing refractory cardiac arrest for more than 5 minutes and receiving ongoing CPR in the ICU. And the point of randomization will be the time of decision made by the clinical team to resuscitate using ECMO. And so that's important because patients in this trial can receive hydrogen before the reperfusion event. So that's really important. We designed this trial and went really to great lengths to architect this trial to allow patients who have ongoing ischemia to be treated with hydrogen. The exclusions are really quite minimal. We are using an EFIC mechanism, or exception from informed consent, which I'll describe in a moment, to enroll patients, and part of that is an opt-out program. So if patients hear about or read about this trial and do not want to participate, then they let us know about their opt-out, and then we will not enroll them. That's an exclusion criterion. The next two exclusion criteria are based on the National Institutes of Health regulations. So we cannot enroll patients who are known to be pregnant or who are prisoners. And then we're only enrolling patients during their first eCPR episode per admission. So if a patient happens to have 2 eCPR episodes and they were enrolled during the first one, they cannot be enrolled during the second one. So, and this is not for elective ECMO cannulation. So this is only with preceding CPR. Really within the last 20 minutes is the letter of the law for enrollment in this trial. So we have 2 primary endpoints for this trial. One of them is feasibility. So that's the fraction of the first 72 hours following the cardiac arrest and eCPR cannulation event in which a patient receives hydrogen through the ventilator and ECMO membrane. And the safety endpoint required a lot of thought and design, and I'd like to credit my colleague, Dr. Lynn Sleeper, for helping us architect this so elegantly. So this is really the daily rate of possibly or probably hydrogen attributable study adverse events. So study adverse events here are characterized by one of 3 things. One of them, the first one, is adverse events of interest. So there really are not any major known hydrogen-related risks or hazards, but we're looking for things that might be related to the study design, the study setup, the fact that we're using hydrogen tanks in the room to feed the ventilator rather than plugging the ventilator into the wall, for example. And so anything related to that, of course, anything related to flammability, etc., which we've really tried to minimize using the way that we've architected the trial. But if anything like that were to pop up, that would be an AE of interest. Otherwise, we're looking for disproportionate AEs, so events that are out of proportion for what we would expect given the clinical scenario. So if a patient had a very long cardiac arrest and had a high lactate thereafter, that would probably not fall into a disproportionate AE. But absent that, if a patient on day 3 or day 4, for example, developed a severe lactic acidosis or a severe infection in a way that was not well explained by the clinical story, that would be a disproportionate AE. These are all recorded by the clinical team. They are checked by an external study monitor who monitors the patient every day and then adjudicates whether we have recorded, the study team has recorded everything. And then it's adjudicated by an external committee outside of any participating center that's blinded to treatment allocation. So they don't actually know whether the patient was treated with hydrogen. The question is really whether the AE could have been caused by hydrogen treatment, whether or not they were. So we are following these endpoints for 30 days following the eCPR event, and then we're doing a 6-month follow-up. And of course, there's reporting to the FDA and to an external data and safety monitoring board as part of our trial. The secondary endpoints that we're examining include survival to hospital discharge, ICU and hospital lengths of stay, looking at markers of ischemic injury, trying to get some early markers of efficacy to figure out how we're going to power future definitive efficacy trials. We're also looking at exploratory efficacy endpoints, including GFAP S100, NFL as the brain biomarkers of interest, and then we're looking at functional status score, which is a clinical score at baseline discharge from the hospital and 6 months follow-up. So importantly, and probably of interest to this group, is how we are administering hydrogen to these patients. And so we did a lot of work that we included in our IND, or investigational new drug application, to the FDA. That included a lot of experimental work of the effect of hydrogen on the ventilator performance. So we have tested Mackay or servo ventilators. We've also looked at Draeger ventilators. That's data is forthcoming in an upcoming publication, as you see referenced there. But essentially, we plug in hydrogen or control with balanced oxygen and air, and compare that to the wall sources as the control. And what we did was we ran through a series of different tests at different tidal volumes, or what you're seeing here are different FiO2s, and do a sweep measuring the FiO2 measured by the ventilator, as well as measured by an external sensor, and then we did some confirmatory gas chromatography. And in all cases, really what we found was that hydrogen has a minimal effect on measured FiO2. What you're seeing here in the hydrogen arm is a dilution effect, because the 100% hydrogen has 2%, sorry, the 100% oxygen tank has 2% hydrogen, so it's really 98% oxygen. And so you're seeing just a dilution down to that 98%, which is, you know, a linear decrease based on FiO2. But this really obviates the need for a patient to be paralyzed, or for there to be any other effects related to hydrogen. And these effects were similarly noted for the Servo U and the Servo I. Looking at tidal volume, we also found that we examined tidal volume across the range, so ranging from neonatal tidal volume of 25 mLs all the way up to 500 mLs or so, both for the Servo U and the Servo I. And what you're seeing here is that the set tidal volume in volume control mode correlated extremely well with the measured tidal volume, and we used as a reference standard a Douglas bag. So as you can see here on this image, we collected all of the gas and essentially computed using the super syringe method the delivered tidal volume. And so I'll refer you to this manuscript when it comes out for the detailed methods of that, how we dealt with bias flow, etc. But nonetheless, these methods were pretty robust and well reviewed by the FDA, that hydrogen administration does not interfere with ventilator performance for certain ventilators. I want to emphasize that. This should not be used with any ventilator outside of an IND. So it's really critical that the ventilator be tested with hydrogen mixtures, because it's not universal that every ventilator is unaffected. And in fact, another important caveat is that the ventilator must undergo a pre-use check using the mixture of interest before use. Otherwise, it does not read the FiO2 accurately. Okay, we also did a similar test and submitted a similar test to the FDA related to ECMO membranes. So as you're seeing depicted here, we got donor human blood, put it into a reservoir, put it through a pump and then a deoxygenator, and then a test oxygenator that was fitted with either 100% oxygen gas or 2% hydrogen with balanced oxygen, and then went through again. And we did a lot of tests that are required by the FDA, looking at oxygen flow, carbon dioxide flow across the membrane oxygenator, and also the architecture And what you're seeing here is that, as you can see here, oxygen transfer was really unaffected. We have a control membrane versus a hydrogen membrane. The hydrogen is in solid. There were no significant differences across 6 days of exposure. And we also did something similar for carbon dioxide transfer. The methodologies for these have all been outlined in the FDA guidance. So it was a pretty extensive set of tests to do. Maybe also of interest was the actual membrane architecture. So what you're seeing here are hydrogen exposed ECMO membrane fibers. So this is 100 microns. These are SEM images of the hydrogen or the ECMO membrane after exposure to hydrogen for up to 6 days. And so at 100 microns, you can see that the architecture of the cross-section fibers is intact, as well as the fiber itself. The cross-section of the fiber itself here is fully intact. So we were quite satisfied with this and have not seen any problems with administration of hydrogen through the ECMO membrane in the patients we've enrolled to date. So in closing, I'd like to also talk briefly about this EFIC mechanism. So this is a sanctioned way to enroll patients in the United States into emergency clinical trials. And I think it's a really important area to discuss with a group like this, because I think when we're talking about doing emergency research, particularly in the U.S., that this is an important way to an important factor to consider. So EFIC stands for Exception from Informed Consent. It's a regulatory pathway by which research can be performed in emergency settings. There are really 4 criteria listed here for which patients have to fulfill in order for EFIC to be justified. And this has to be reviewed by and approved by both the FDA, the funding agency, and the institution of interest. So in this case, this was the FDA, the National Institutes of Health, and Boston Children's Hospital, IRB, and by proxy, a community consultation was performed. So the intervention must be administered before consent can be obtained. That's really true. Even if you extend this window out to 6 hours in the setting of cardiac arrest, particularly in the congenital and child environment, that is an extremely difficult thing to do. And I would argue that informed consent is really not possible in any setting of cardiac arrest within 6 hours. So I think this should really be applied to any treatment paradigm in cardiac arrest. There's no reasonable way to prospectively identify individuals who are likely to become eligible for participation, meaning you can't predict a cardiac arrest. And we're certainly not good enough at it to do so accurately. Participation in the research holds out the prospect of direct benefit to the subjects, and that the clinical investigation really could not practicably be carried out without the waiver. So we feel that this trial met these criteria with no problem, and that was agreed upon by all the groups that I just mentioned. So generally, families and parents and prospective patients are informed about the trial. This takes place through community consultation. So this is meetings with families and patients to review the protocol in detail, including the EFIC process. We went through all of the data that I just showed and a lot more, including a lot of the work from my colleagues here at the on this symposium. We then also do ongoing public disclosures. So we have a public facing study website, which you can find if you just Google hydrogen and Boston Children's. There's a YouTube video, references to many manuscripts for people who want to read the primary literature. There are social media posts through the marketing department, and then there's flyers distributed in the waiting rooms as well as in every bedside of every ICU room. That really shows at a high level what this study is about. So this is a little snippet of the public disclosure form. So you can see here there are opt-out forms. You can email the study team. You can visit the study website. These are some high-level questions, etc. Opting out essentially means that a family or a patient wishes not to be enrolled. They've read about the trial, they watched the YouTube video, they talked to a study team member, and they say, this is not for me. So when we learn about those patients, whether that be through a phone call, or we have a study phone number, a website, an email, those patients are identified in several ways. One of them is a do not enroll in the hydrogen fast trial. That list is stored next to the hydrogen tanks, and that's really the primary screening mechanism, and I'll show you a picture of that in a moment. Then we put a red bracelet on the patient that says no hydrogen on it. We put a sticker on their nameplate outside of their door, and it's passed along as part of clinician sign out. Hey, if this patient has an eCPR event, don't enroll them in the trial. Absent an opt-out, those patients who meet inclusion criteria and do not meet the exclusion criteria we reviewed can be enrolled without prior discussion with the family, and then the study team meets with the family as soon as is possible to discuss the trial. So the logistics of this trial on our unit are shown here. There are hydrogen tanks that are kept really right next to the ECMO circuit, so that as we go get the ECMO circuit, we can also bring the hydrogen tank along with it. Here is the do not enroll list that I mentioned. We have two strata of randomization, neonate and non-neonate. So there are two randomization envelopes, and then the enrolling provider, who is basically a bedside provider, opens the envelope that corresponds to the patient's age. And then if they're randomized to hydrogen, then we enroll and start hydrogen administration, again, as early as possible, but making sure not to distract from the resuscitation efforts. That's an important balancing measure that we're keeping track of in our unit. So this is one of the patients that we enrolled, what their bedside and what the setup actually looked like. So as we enrolled the patient in the trial, we brought the tanks into the room. We attached the ventilator directly. You can see in the back here that the oxygen and air lines that came out of the ventilator attached directly to a manifold on the back of this carriage, which essentially allows us to attach to daisy chain multiple tanks. So there's two air tanks and then two oxygen tanks separately attached to each manifold. And these really allow us to ensure that the tanks do not run out, and it allows some time for, so that we're not always bothering the bedside team. So really we went through about 3 sets of these tanks in 72 hours for the first several patients that we've enrolled, and that's gone very well. So the science behind hydrogen is compelling. With proper testing and approval, hydrogen mixtures can be administered directly through the ventilator and ECMO membrane. And this work really lays the groundwork and provides really exciting opportunities for several future clinical trials in the US, including in-hospital and out-of-hospital cardiac arrest trials, stroke, sepsis, ARDS, and many others that I'm sure you can think of. So if anybody's interested in pursuing any of these trials, we have a network here in Boston that's Boston-based but reaches across the United States of other sites that are interested in participating in these clinical trials. So I encourage you to reach out to me with any questions or comments. Thank you very much, and it's been a pleasure talking to you.